Κυρίες και κύριοι συνάδελφοι, καλημέρα σας. Κωνσταντίνε, μ' ακούς? Ο κύριος Τούτουζας.
Σας ακούω πάρα πολύ καλά και σας βλέπω πάρα πολύ καλά.
Καλημέρα, Κώστα.
Καλημέρα.
Good morning, Carlo.
Καλημέρα, Βασιλικός.
Nice to see you again, and we're very sorry you're not here with us.
Me too.
I know, me too. Okay, thank you very much for being with us. This roundtable has to do with what's new in the treatment of atrial fibrillation. I co-chair this session with Professor Tούτουζας, who is the president-elect of the Hellenic Cardiac Society as well. And it's an honor for me to present Professor Asmundis, who is going to talk about the new toy, I would say, the pulse field ablation. Is it so good as they say, Carlo?
It seems well.
Okay, so
It seems well.
The stage is yours.
Thank you so much. And again, I'm sorry to not be there, but I'm happy that I can participate in this way. My presentation is about the new tools, and then everybody talk about. Actually, it's nice to see that the first time in electrophysiology, the people get interested in something before even having it on the hand. So PFA became quite popular before it was available. I will talk about this three topic. The durability of the lesion, of course, we know that was always a big discussion. You know, the story about the radiofrequency eclair balloon was a one step forward to get a more durable lesion. But honestly, become impressive with this device. And that's some number about the durability of the lesion. But what I want to make a remark is that you have to use the device for what it's designed for. Because there is one point, the moment you provide, you deliver the first lesion, all electrical signal disappear. That doesn't mean that all ablation is done. It just means that the whole cell are stunning, because the electrophysiologic effect is that this energy will create electroporation, so it will create a hole in the membrane of the cell. But only when you reach an amount of hole in the cell, then you can induce apoptosis. So the sequence of the lesion are quite blinded, because the first, when you ablate it, the rest is just thrust of the device. That's the reason why the device is durable if you use in the way it was designed, because the design was made out of histological checking. That's actually one limitation. This is showing how, of course, if you perform and a posterior wall combined with the PVI is getting a quite higher effect, higher durability. Fortunately, the posterior wall is the thickness of posterior wall is similar to the PVI, so the devices are designed for a PVI seems to be quite effective on the posterior wall too. It's very important that just to tell you about our experience in some PVI device, the lesion was so extended that in the first cases it was leaving a kind of bridge on the roof. And so we had two roof-dependent flutter, because the lesion was so extended that it was a quite of narrow gap on the roof. So now most of the time we perform PVI and we close the roof, because the lesion is very antral and is not distal for some of these devices. But of course, if you combine both of them, the lesion is very durable. Now, transmurality is something that we discuss, and not all devices in all positions are transmural. That should be clear. So we are not really, again, if it's designed for PVI, you get transmurality. If it's designed PVI posterior wall, you get transmurality. If you use on the mitral line, you will not get transmurality, because then you challenge yourself with thicker tissue, and that's when you get challenged. And you cannot understand during the procedure. That's the main problem, because you do not have any end point, because all signal disappear. But if you use for what is then you have a very interesting and complete transmurality. This is one example of a redo, and then the device was using with two less delivery on that area, and then you can see that the transmurality was not acquired. The fistula was something that we always discussed before about this problem, and fistula, of course, is something that should be taken into consideration. Now, with this energy, it's something that seems to be gone. The story that the PFA doesn't warm the tissue, so you do not have this warming effect. We know that the fistula as a very complex physiopathological process. It's not just burning the esophagus. It's probably some kind of induced ischemia of the musculature of the esophagus, probably that is develop a kind of necrosis that will be clinically significant 1 month later. So this eating effect is not there anymore, or anyway, it's very minimal. It doesn't provoke any lesion or on the esophagus point of view. And that's actually make this procedure very safe. I mean, this safety around this energy, it makes the procedure more easy in a way that the operator feel more confident and has, I don't want to say less attention, but let's say he has less worry about provoking several complications like fistula or eventually frenulum nerve palsy. So these are all effect of a PFA. So these are all parameters you should follow. So the design of the catheter play a role. The contact before was not an issue because the engineer was telling us that this energy source, it doesn't matter about the contact. In fact, many of the design in the beginning, many of the device was designed in the beginning without any contact feedback. And that was a mistake because actually the contact play a role. Now, the engineer cannot explain that yet, but it seems that if you are not in contact, there is an idea of the blood take over some of energy, so it doesn't let eat the tissue in the right way, so the contact can provide the correct energy. And also there was a discussion about monopolar or bipolar. So monopolar is from the catheter to the patch, and bipolar is by two electrodes. Now, what any company is actually patent, because the PFA, it's coming from the 70s, so the PFA himself as a concept cannot be, it's a free concept, so it's an open source. But the way that they deliver the energy, it's something that is crucial and specific. So each company is testing different way to deliver the energy, and then you cannot compare easy one device to another because you are compare Milo mer portocalis. So the point is that you cannot compare them together. And that's why a big issue, because before we could compare easy radiofrequency catheter, now we have to pay attention to do that by standard. The orientation of the catheter, just to make an example, the multi-electrode catheter, it seems to be quite effective and it works very well. But the contact that now is coming up, a new device with a balloon design, by chance, I mean by opportunity, they have more contact because the balloon is occlude this vein and seems to be faster and I don't say more effective, but the question that with one device you have to deliver 16 or 18 application per vein, with the other one you have to deliver 2. So you immediately understand that increase the reproducibility of the procedure and also the learning curve. Now, this is a device that I was talking about. Starpulse is one of the first that is a breakthrough in this PVI world of PFA. Is very effective. Again, you have all these geometry because the geometry play a role. So you have to perform lesion with the basket form, you have to perform lesion with the flower form, and you have to overlap them. So this is very crucial, and it's anatomical. I'm sorry for the one that they love the signal, but we are going again to showing that the PVI posterior wall is an anatomical approach coming from surgeons, and this you have to really design your lesion around the vein and rotate your catheter in a different geometry to perform a complete durability, sorry, and transmural lesion. So this device how it looks like if you never saw, so he has a specific form. As you can see on the chassis, you have a 3 figure, and if you move down this orange clip, you can shape the catheter in different form, and there is this flower form that was never seen before by a catheter ablation, and that you make this very high characteristic. These are the devices that exist today. Of course, was easy for many of the company a circle catheter transformed in PFA because technologically you just need to change, and delivering PFA through a diagnostic catheter was also easy. As you see, there are some catheter look like a circle catheter that was before diagnostic became ablation catheter. The pulse actually come from the old, I don't get the name now, but it's the the ablation catheter was RF designed. And then actually in the innovative way, it seems that the spheric geometry play a big role in this energy because it can deliver homogeneous the energy around. So you can see you have this sphere PVI that is coming up, is not yet approved, but the study running, and it seems to be very promising. Again, the sphere make a very high contact on the PVI point of view. There is the catheter of the Affera exists and is a small sphere, and it seems again that the sphere is working very good around the field. Then there is some other company that we try different shape, but still everybody now are looking for a contact because that's what the first study is showing. These are the point device. You see there is from a Faraflex still create a kind of sphere shape. And the Sphere 9 Affera is the one that is now acquired by Medtronic. Is getting up more and more. It just seems that after acquisition, Medtronic has to rebuild the whole facility to build the catheter. So there is a slowing down of delivery of the number of catheters around the world. But now the new facility are ready. So I think it's a question of time before this technology really spread around in a way that should be. And just to let you understand, for our today what we do first line Farapulse PVI, eventually roof, and for redo case we do Affera device. Affera device is at the moment unique because it has a dual energy effect, so it has a radio frequency and PFA on board, so you can perform radio frequency in region there where you can expect some reaction. Or you have a very thickness tissue, so you want to combine the both effects. Studies showing that the biphasic being more effective than the monophasic. I will not go deep on this study, but just in a concept point of view. So most of the devices are coming out more and more biphasic because the biphasic showing to have a superiority. The durability again, there was a study for Vigretti showing that the posterior wall, if you combine the PVI with the posterior wall, you have higher durability. Consider that that's the reason, because you will overlap your lesion of the posterior wall with the PVI, so it will improve also the lesion on the PVI. All this is a blind box, because when you perform your lesion, everything is gone and it looks like beautiful, but then you have a chronic remapping, and you see that when you do PVI in the D panel, you will have a small reconnection there. It's easy to understand in a C panel that if you perform the posterior wall, you overlap a lesion over there, and then you will consolidate this part. Consider that the C panel is what you see in acute phase. So C panel or A panel, in acute phase, you see something like that. Few hours after, you can start to see something different if there is no transmurality, but takes days before you will see a picture like in the panel D. Just to let you understand, so in acute phase, you are not doing anything wrong. So in acute phase, if you map, you will see a full lesion done. We did a study with the thoracoscopic to see the transmurality in a real way. So let's say we went to measure from outside this an arrhythmia system, and we went to measure the idea, and we saw that we were not able to ablate from inside the mitral line. So the surgeons help us to do part of the mitral line, and finally we get transmurality over there. This was, let's say, 1 hour later, we applied the lesion over the mitral line, and then after we get transmurality of the mitral line. Again, this is just to show you, we map epicardially, endocardially, and we saw that for some device, like if you don't deliver enough energy on the posterior wall, just to let you understand, enough energy means that you have delivery above 100 application to do PVI posterior wall. In total, there is an amount of under 120 application. Depend on the operator, but let's say it's very crucial to be to have an idea to be transmurality. This is the esophagus, and then you see the pulse field showing that there is no any lesion, even not temporary lesion or reversible lesion. So there is nothing on the esophagus point of view. Then was also studied in histological point of view to see the lesion. And then there was one case, because of course the real life is always different. Somebody was able to perform to unfortunately have a problem of esophageal injury. Now, honestly, in all cases that I saw observed that we do and I saw around, this is not really an issue. But I mean, of course, you have to be aware that one case was happening about that. But for the stenosis, there is no issue. So it seems that really this device doesn't create any problem on the stiffness of the stenosis. And then I go fast to our experience. So we try most of the devices that are available. We publish some experience. So because as a big training center, we would like to show what is the transition between the people from cryo balloon going to a single shot parapulse device. And it's very smoothly. So if you have an idea of radioscopic geometry and anatomy, it's very easy to apply with the switch to the Farapulse because your experience in manipulate catheter around the ostium is crucial to acquire this device. It takes longer, of course, if you are not coming from this single experience lesion. So today, also, I want to underline that soon, I mean, soon is next year, the Boston Scientific will come with a mapping system, so probably it will also improve and shorten the learning curve to use this device. A study showing that the event, of course, this seems to be the promised land for PVI ablation. I'm not saying from AFib ablation because do not consider AFib done. But in our experience also, we have a multi-center experience with the Farapulse. We have many hospitals involved, and we compare the cryo balloon radiofrequency and pulse field ablation, and then we show that, of course, there is a serious superiority of the PFA in any topic. Any topic means in a type of procedure, in isolation, in safety, in all these characteristics, and as you see, of course, the PFA curve is as the best survived. Now, there is a huge paper where we participate also, and it's a manifest 70K, so 17,000 patients collected to see what was the outcome and still confirm our data in a small multi-center study. So the trend of this data is quite consistent all over the world and is going to consolidate this idea that device designed for PVI posterior wall, they are getting superiority on all the rest of the devices on the market. Now, there is different PVA strategy. Of course, there is a real world experience. Of course, everybody wants to make his own signature, and it's still market is open because there is no a real idea how to approach with this new device and what to get the best outcome and to get the best feedback during the procedure, but that is a small experience apart the last one, and then you see that anyway the result remain consistent. That with the multi-analysis, one of our fellow is there just to try to figure out to make a multi-analysis of whatever is around between cryo PFA to create a comparison, and is confirm the data that we had in real-time clinical data on the side of the PFA. These are just to show the comparison part, and these, you know, today these are under review, but soon will be published because we are responding on the first line of reviewer. So we are confident that will be accepted soon, and then showing that there is a the procedure time. Consider that with the cryo we perform one lesion in 3 minutes. With the other one, we have to perform 16 lesions and sometimes take 3 minutes. So the point is that that's the reason that you don't have a drop dramatically of procedure time, but still you have an advantage of the other device. And I think it's come more from a confidential feeling of the operator because he's not searching for phrenic nerve, he's not afraid to perform any lesion. So I think it's get faster in that way because you can easily rotate and ablate. With the cryo, you should pay attention, of course, because it was always the risk for the phrenic. These are the burden. Of course, if you have, now in my experience, I can tell you this, just to interpret this, if you have a burden in the early phase, means, in the few days, means that there is something reconnected. So it seems that you don't deliver enough in one region, and so there is part reconnected. Otherwise, if the patient go well for a long time. Now we have a follow-up of almost 2 years, 3 years. And see that really they get free of ablation and redo them with the PFA to close this gap. It's also consolidated the situation, so it's really getting quite consolidated result of this technology. This to show that is the PFA shows very antral lesion. That's what I told you. And then on the roof, you have to be careful because if you do only PVI, if you have a small atrium, the gap you leave on the roof could be so narrow that you can promote an re-entry flutter. So sometimes we perform some application to close the gap and to do the roof line. Let's say talk about the old style way. These again are paper that's showing the advantage between the cryoballoon pulse rate radio frequency and still create kind of competition with the cryoballoon and PFA. But I think also because when you involve a lot of centers, then there is a problem that there is still learning curve that is not measured, but it's quite smoothly. And then there is the using for a persistent AFib. Of course, if you can do PVI and posterior wall, so now there is an idea to move on PVI posterior wall approach for a persistent and see how it evolves. Now, I think I will not annoy you longer with this data. There is only one specific complication was never saw before, that is a coronary spasm. The coronary spasm when you perform some lesion close to I mean, you can have it in few regions, but of course, if you get close to the mitral line or inferior vein left side, you can have this spasm. It's not dramatic. Actually, of course, in the beginning, we were not expected, so we did a coronary angiogram to see, but it's really few minutes. And now we publish, of course, and also other group publish experience that if you perform and a pre-medication with a nitrate, you can prevent this problem during your procedure if you want to do the mitral isthmus line with a parapulse, for example. That was the example. So this is actually, just to keep in mind, there is a specific problem that you can provoke in muscular stimulation. You will see also when you use the device that, and I know that in Greece it's not common to use a general anesthesia during atrial ablation. I mean, I don't know if it's still like that. When I was there, not everybody has this opportunity. It's very painful if you do with the patient away, because there is a stimulation of all muscle, thorax muscle. I mean, it's really, that's only the annoying part of this, and that's also reflect the fact that you can stimulate the muscle of the coronary artery, and you have stimulation of the muscle of you stimulate also the phrenic without damage, but you have a movement of the phrenic, the diaphragm do from a phrenic stimulation. The stiffness of the atrium is not really an issue in this case, and there is no hypertension post PFA ablation. So to see if there is a clinical effect of the small stenosis, because of course if you go to measure, you always see a little bit remodeling of the osteum, but it was not significant. And so we cannot talk about stenosis, a clinical point of view, and also the stiffness was not present because there is no any clinical effect of this. That is the other trial that we are running, and there is also a center in Athens participate in this, and we try to we again try to collect and improve the comparison between cryo and PFA, and that is showing and confirming again this data for the future. I mean, this is the result. Of course, the lifetime risk it's more than 30%. Of course, this is a compare that you have the AFib create a risk, and now with a device that is a low risk effect, you should not, in my opinion, even and that could be a very provocative sentence for a cardiology in the room and not for the AP. You should not even try drugs today. I think you can easily go for a first line ablation, even more than the cryoballoon now. Thank you very much from Brussels, and I'm open for any question.
Thank you very much, Carlo. Very nice talk. And so you showed that there is a little bit of that PFA is a little bit ahead of cryo. That's my understanding, right?
Yes, it seems really going that direction. I think there is some difference in a way that there is a big question. So the PFA is subselective on the cardiomyocytes. So it seems it doesn't affect or affect only indirectly the neurosystem. So the cryo was more neuromodulate this patient. we saw that there is not a huge, also we published, there is not a huge neuromodulation like we had in a cryo. Today we have to learn if this, what is the role of this part. But for the electrical point of view, is ahead of cryo, yes.
And do you feel that all the PFAs are the same, or each company has, you know, it's a little bit of marketing, but you've tried these technologies. What's your gut feeling?
No, that's a good question, and actually we have to stress this. You cannot compare them. I mean, each device come on the market has to go through all process and be validated. It's not because you're using PFA you can trust immediately the device, and it doesn't mean that it works automatically because you're using PFA due to the experience you have with another one. So I think this will be the challenge for the company. Every time they come to the market, they try to link them with data from other. But in this case, and it's the first time actually, it doesn't work at all. So do not be fascinated by people that come with a few data because they're not enough to trust the device. On the other hand, I see an opportunity from us as a scientist that this very selective ablation of cardiomyocytes maybe finally will give us and link us to the understanding of the disease, because I don't think the AFib is done with this device, but I think we can really understand when the patient comes back, because most of the time the PVI is done. So I will see a patient divide between a PVI responder, a PVI non-responder, and then maybe clinically, scientifically, we can go deeply to understand the disease. But as you say, do not trust in the device coming out with a few data, because each device has to be considered as a new technology coming in the market.
You already answered my next question, because you know we have good tools, easy tools, safer tools, but the success rate remains 70%. So we're missing something. And well, I think we don't understand exactly the pathophysiology, or at least in some patients.
You are completely right. Actually, what we did in the last 20 years, we achieved the best way to isolate the vein.
Yeah.
We didn't achieve the best way to treat atrial fibrillation. Sure. We have the best way to perform an isolation of the vein, and I'm happy about that. I mean, I'm not saying as a negative point. And the posterior wall. I think that was let's say, industry drive, because the industry developed a lot of device, but was less investment in physiopathological understanding. But I think today we have the best tool to isolate the vein and perform the posterior wall. Now, the disease is something more than that, fortunately, in a way, and it's very so. I see also an opportunity. The patient will be treated sooner, I guess, because the access to the ablation, and maybe we will face in 10 years a different remodeling of the atrium, because if we treat very early and we do not spend time to give drugs that at least the drug they still stable, so they not work and they still don't work. I mean, it's not that they change their efficacy. Treat them early, maybe we prevent a kind of a bad remodeling. I don't know, that's something should be studied, but the progression of disease in the future with this device should be linked to more understanding of a disease. But for sure, I agree with you. We just achieved the best way to isolate the vein posterior wall.
Yeah, thank you. Any questions? Okay. Carlo, thank you very much for being with us.
My pleasure. Enjoy your Congress.
We hope next time you're going to be. We'll do it in Mykonos. Yes?
Then I already take holiday now. Then.
Okay. Okay.